Good evening, everyone, and welcome to the webinar. This evening, we'll be talking about treatment for incurable pancreatic cancer when surgery isn't an option. As a reminder, this session is for anyone affected by pancreatic cancer, whether you've had a diagnosis or you're supporting a friend or family member who's had a diagnosis. My name's Simon Walker, and I'm a specialist nurse here at Pancreatic Cancer UK. Prior to joining the team, I worked for several years as a palliative care clinical nurse specialist, and that was both in the community and also a hospice inpatient setting. And during that time, I've supported many people living with pancreatic cancer. Now, without further ado, I'd like to hand you over to my colleague, Lynne, who'll take you through the content of the webinar. Over to you, Lynne.
Cheers. Thanks, Simon. It's a pleasure for me to be chatting with you tonight. My name's Lynne, as Simon said. I'm one of the nurse specialists here at the charity. I've been involved with the care and support of those affected by pancreatic cancer for over 20 years, and my background is oncology. I was a chemotherapy nurse and then a HPV nurse specialist at the Christie up here in sunny Manchester. Tonight we will be discussing the main treatments for incurable pancreatic cancer, and this includes chemotherapy and radiotherapy. And I want to spend some time also discussing the importance of keeping well before, during, and after treatment. I wanted to try and make this session as practical as I could. So I will be sharing thoughts on things that you might want to discuss with your healthcare team. But also tonight is an opportunity for you to share your experiences and top tips with each other. So as I'm chatting, if you've got any top tips or thoughts, please pop these in the chat. And as Simon mentioned, we'll have time at the end of the session for Q&A. So please keep adding those as we go. I wanted to spend a couple of minutes firstly chatting over what happens in the lead up to you being offered treatment, how the team and yourselves might come to the decision of what treatment is best for you. There are lots of pieces of information that need to come together before treatment can be planned. These include things like scans, biopsy results, and how well you are. This information is brought together and discussed at a big team meeting called an MDT meeting, and that stands for Multidisciplinary Team Meeting. These are usually based at the specialist surgical centres, but your local hospital will feed into these meetings as they know you best. People that are at these meetings will be surgeons, oncologists, pathologists, dietitians, research teams, nurses, and other support links. As with all treatments, weighing up the benefits and burdens of each option is essential for you to make the best decision. Remember that this is your treatment. It's important that you and your family feel part of the decision-making process. And we'll go over these considerations throughout our presentation tonight. Chemotherapy. So what is chemotherapy? So chemotherapy is one word that we use to describe lots of different drugs. And we use all these drugs in lots of different combinations. How chemotherapy works is by killing cells. But it's not clever enough to know the difference between a good healthy cell and a cancer cell, so it affects all cells. It's something that we call a systemic treatment. What this means is it goes around your body and it attacks any pancreatic cancer cells that's located anywhere in your body. So this is why it's used to treat both locally advanced and metastatic pancreatic cancer. And the aims of chemotherapy is to control the growth of the cancer, extend your life, but most importantly, maintain and improve your quality of life. We use different drugs in different combinations, as I've said, to treat pancreatic cancer. We call these combinations regimes. I wanted to include some information on the most commonly used regimes so that you're familiar with the words that we use and what you might hear in clinic. And also you can see that each regime, it can be slightly different. One full dose of treatment is called a cycle. And you'll see on this slide that FOLFIRINOX, their one cycle is 2 weeks. But gemcitabine Abraxane, one cycle is 4 weeks. And one full dose of treatment is called, I've just done that, excuse me, pardon me. And the things to think about when you're considering chemotherapy is that chemotherapy usually lasts around 6 months. So you'll be having treatment throughout that time. You'll have to have bloods taken before each dose. So for FOLFIRINOX, that will be having bloods done every 2 weeks before your cycle. But if you are having gemcitabine Abraxane and you're having treatment for 3 weeks and a week off, you'll have bloods before each of the doses, each of the weekly doses. You need to have scans before you start your treatment, halfway through the treatment and at the end. And this is to ensure that the treatment that they're giving you is having the desired effect. I think it's really important to mention that the scan before treatment is something that we use as a baseline. So it's something that we compare future scans on. So that scan really needs to be quite close to your starting treatment. And so this would be something that I would be chatting to the team about before embarking on any treatment, is that you've got something called a baseline scan. And with chemotherapy, I think it's really important to stress that one size doesn't fit all. Sometimes you'll hear us talk about, FOLFIRINOX, using 3 drugs is better than using 2 drugs, and 2 drugs is better than using 1 drug. But that's on paper, and everyone is different. So sometimes people will have the 2 drugs and have a great effect and a fantastic quality of life, and it helps to control their cancer. So like I say, one size doesn't fit all. We talked about the need to weigh up benefits and burdens. And I think it's important to talk about these in a little bit more detail. That the benefits of chemotherapy can be that it controls your cancer, it extends your life, and it improves and maintains your quality of life. And some things that people will consider is the fact that you don't need to stay in hospital anymore to have chemotherapy. You can have this all done as an outpatient. But the burdens of chemotherapy can that people will get side effects. Chemotherapy is a blunt instrument, so there's uncertainty. We don't know who will benefit from chemotherapy and who won't. And you do have to have blood tests and scans and frequent trips to the hospital, and potentially an admission to manage the side effects. And all of this has an effect, an impact on your time. So it is quite time toxic. It is going to take up some of your time over that 6 months. And that is things that people, and elements that people want to consider before embarking on treatment. Radiotherapy. Well, what's radiotherapy? So there's 2 types of radiotherapy that we use. An external beam radiotherapy, which is the more commonly used and well-known type of radiotherapy. And there is a newer, more precise radiotherapy called stereotactic ablative radiotherapy, which is a bit of a mouthful, so we call this SABR. External beam radiotherapy is given with oral chemotherapy, and the chemotherapy is a little dose of capecitabine, which you may have seen the name on the previous slide. And that's taken orally, and it makes the cancer cells more sensitive to the treatment, so therefore helps it work. And as I say, this type of chemotherapy has been used for many years. The SABR is the new type of precise radiotherapy. You may have heard it called CyberKnife. I think it's important to say that the effectiveness of both of these treatments are very similar. But SABR delivers high dose of radiation in a shorter time, which reduces the number of days that people need to go to hospital. And there's a more precise field of treatment, which can potentially reduce the side effects. External beam radiotherapy is widely available. However, SABR is only available in a few hospitals in the UK. The benefits of radiotherapy are that treatment is relatively quick. It's a big X-ray machine, and so people will have a number of days of treatment, but they'll go in and it'll take a couple of minutes. As I've alluded to, you don't have to be as an inpatient or given as an outpatient. There can be fewer side effects compared to chemotherapy. It can help to treat the cancer, and it can help with symptoms. And the burdens there are side effects. You have to travel every day to the hospital. Not everybody can have this treatment, and it's only available to those with locally advanced disease. And radiotherapy is given mainly after people have already had chemotherapy. So people will have had 6 months of chemotherapy, and then they will have radiotherapy. And there comes a challenge, that potentially people have some longer impacts of chemotherapy and start radiotherapy, so you can have a few more side effects, but speaking to your team can help manage them. I wanted to have a think about what might be useful questions for you to ask your team whenever you're discussing your treatment options. Remember that clinic is your time. Go with a list of questions, and there is no silly questions. If you're worried about something, or you don't understand something, or why something's being offered or not, you must ask them. And I'd always say as well that you don't have to wait to be in clinic to ask a question. You can seek advice and support from your clinical nurse specialist. And of course, you can get in touch with us here at the charity, and we're happy to advise as we can. So some of the things that I might consider asking would be, what are all your treatment options? Why are you being offered the treatment options? What are the benefits? What are the burdens? How many visits to hospital might there be? Can you have treatment closer to home? Lots of places now are doing chemotherapy in mobile chemo units, and it's worth asking because that can make the burden of travel much easier. And most importantly, I feel when people are on treatment, as who's my point of contact in the team, and who is my emergency contact whilst on treatment. And I also think it's really important to ask, perhaps, are there any other treatment options available to you? And I wanted to include this quote from Chris, who's living with pancreatic cancer. She had FOLFIRINOX chemotherapy recently. And she just said that her top tip to you all would be ask questions all the time. This is your cancer and this is your treatment. And I couldn't agree more. I think this is a real key point. I've already alluded to the importance of keeping well, and I believe this is something that's actually should be woven throughout your pathway and should be a priority for you and your healthcare team from diagnosis onwards. I wanted to spend a little more time now chatting over things that I thought might be useful for you to have a think about before starting treatment and for during and after your treatment. And remember, pop any questions that might crop up from what we're discussing in the Q&A. So preparing for treatment, I know that waiting to see the oncology team to discuss your treatment options can feel like a really anxious time. And people often describe to me that the feeling that they just want to get on with treatment as quickly as possible. However, we know that taking some time preparing for treatment and treatment discussions can really help people to be as well as they possibly can before embarking on the next step. But most importantly, taking time before starting treatment to focus on your well-being will help you to improve and maintain your quality of life and perhaps tolerate treatment better. Being seen by oncology in a timely way is, of course, really, really important. But perhaps think about the time between appointments as an opportunity to work with healthcare professionals on tackling the symptoms of pancreatic cancer. And we know that focusing on diet and digestion is a priority for people with pancreatic cancer. Alongside exercise and emotional well-being, this has proven to, there's evidence to prove that this keeps people well before, during and after treatment. I wanted to share some of my thoughts on how to keep well on treatment. I think before starting treatment, you have to ask how the treatment might make you feel. And sometimes I think that it's hard to prepare people for how they might feel and explain it fully. Sometimes you have to experience it to fully know how it will affect you. However, there are common side effects, which we'll touch on in a moment. But you should be given written information on the proposed treatments that's being offered to you to take away with you and to read and to ask questions about so that you can give informed consent. You can also find information on our website about the treatments for pancreatic cancer. It's important to ask how the side effects might be prevented. Often the commonly experienced side effects will have preventative medications, and so you must take these as instructed. If these don't help, tell someone. We must also manage any symptoms of pancreatic cancer alongside any side effects of the treatment. Side effects need to be managed proactively, but what do I really mean by this? Often there are patterns to side effects. For example, your chemo may make you feel sick, but you've noticed that this is only on day 3 to 7 after the infusion. And I think that I would recommend that if you're embarking on treatment, keep a diary of how you feel, and that will pick up any of these patterns. And if it was that you felt sick on days 3 to 7, I would suggest taking additional anti-sickness for those days to prevent the issue. My motto always for side effect management is prevention is better than cure. But again, if you're still experiencing side effects, even with this increased management, you must let someone know. Discuss how you feel with your team at every review. Call your clinical nurse specialist to discuss any non-urgent niggles. And again, remember, there's no silly questions. If you're worried about a side effect or how you feel, just ask. Your team will be able to offer ways to manage side effects, but only if they understand exactly how you're feeling. We know that treatment can cause side effects. Some are more common with chemotherapy, and others can be more specific to individual drugs and treatment. And there's things that people commonly associate with treatment and things like nausea and vomiting. And we've already touched briefly on the fact that prevention is better than cure. But if you have nausea and vomiting that is unable to be improved with the medication provided, you must let people know. Diarrhea and constipation can be common issues, but also some of the medications that we treat nausea and vomiting with cause constipation. And sometimes people we need to then treat the nausea and vomiting, but then also treat the constipation that is as a result from treating the nausea and vomiting. And so it can be a lot of tweaking and adjusting, and that is why communicating with your team and asking questions as you go is really key. Low blood count is something that happens to everybody on chemotherapy, because you'll remember at the first slide or second slide how chemotherapy works is by attacking cells, but it doesn't know the difference between a good healthy cell and a cancer cell. And so it affects the bone marrow, and that's where the white cells and the red cells are produced. You might go for chemo and have your bloods taken, and the team say, oh, we can't go ahead this week, you've got a low blood count. And that might not mean much to you, but it's important to ask that question. What does that mean? Is it a white blood count and they're the ones that fight infection? Or is it a red blood count, and that can be the platelets, so the things that knit you back together if you cut yourself, or hemoglobin, the cell that carries oxygen around your body. And it's quite common for people to have effects on their blood count. And how we might manage that is by having a week off chemotherapy and allowing your bone marrow and your bloods to recover naturally. If it was to become a problem that happens a number of times, it might be that they need to think about adjusting the dose of your chemotherapy. This is a normal and safe way of managing things in regards to side effects. Sore mouth and taste changes are exceptionally common with the low blood count. If you've got a low white cell, which are ones that fight infection, you find that the bacteria that are living in our mouth and in our digestive system quite happily normally, because sometimes go a little bit wild if the white cells are low due to chemotherapy. And something that people can suffer with is oral thrush. So if you're starting to think you've got a sore mouth, it may be ulcers because the cells in your mouth are rapidly dividing, and chemo loves that. So prevention is often better than cure. You might find that you would use a mouthwash to prevent the little ulcers. If you're finding that you've got a strange taste in your mouth, always take a look in the mouth and see if there might be a spot of oral thrush. If in doubt, you call the 24-hour chemotherapy hotline. And these are more specific. The other things on these lists are more specific to certain drugs. Certain drugs can make you sensitive to the cold. Certain drugs may give you sore hands and feet. Or certain drugs may give you a reaction while it's infusion. If you're having chemotherapy or treatment and you feel unwell while it's happening, you must let someone know straight away. All of these possible side effects and how we might treat them and the impact that they might have on your life should be discussed with you before starting treatment. As much as I can share with you my thoughts and top tips when thinking about keeping well on treatment, I think it's always so valuable to hear from people who have personal experience. So I wanted to share with you a short video clip from Claire and Bradley, where they share with us their experience and thoughts on chemotherapy.
If things are going wrong, is not to be frightened if your doctor suggests getting the dose reduced. You know, we were terrified of that happening, and actually, you know, thinking back to those first 2 doses of FOLFIRINOX that you had, which absolutely trashed you, you had it reduced down to like 60%, and the difference was astonishing. And interestingly, the first routine scan you had after that still showed that it was having some effect. But it meant you didn't end up on the chemo ward with neutropenia for 2 weeks. Being prepared to have those discussions with your doctor and to take your doctor's advice is really important, isn't it? And I think that the key thing here, the theme, is about assumptions. So it's that assumption that it's only going to be a 100% dose of FOLFIRINOX that's going to work. And, you know, it was suggested to us after your 3rd bowel obstruction, or whatever it was, that actually there's no way you could continue with FOLFIRINOX. It's just way too toxic for the bowel. And GemCat was suggested, which, you know, we were thrilled that there was another option, but we were, you know, we were advised this probably won't do anything. You had a year of that, and for 7 or 8 months of that, you know, the CA19 just came down, and, you know, you did really well on it. And so it's about not having that assumption that there's only one thing that's going to work.
Fabulous, Claire and Bradley there, who say it far better than I ever could about some of the challenges and thoughts on chemotherapy. So I wanted to talk a little bit about the help that's available to keep you well. And some of these things you will have come across and thought about and having a chat with your family and your medical team perhaps about. But I wanted to discuss them in a little bit more detail. So palliative and supportive care are 2 words to describe a mode of care and support, if you like, that you can access at any point from your diagnosis onwards, in theory, but actually are services that can help you to keep as well as possible for as long as possible with your diagnosis of incurable pancreatic cancer, and can also help to open up treatment options to you. But it's an ongoing discussion, and I wanted to just highlight the possible avenues of support that you might consider, you might have already considered, but things that you might want to discuss again with your family or healthcare professionals about accessing. So there's various different people who can offer this support, but we don't know they exist unless we know they exist. And it might be that there are different opportunities to access palliative and supportive care through your local cancer support centres. Some of you may have heard of the Maggie's centres. Maggie's are our cancer centres that are run by a charity, but are often nearby to hospitals. You might have one in your area, and they can offer such things as complementary therapists, referrals for financial and benefits advice, different support groups, yoga, and also disease-specific support. So it might be that the local cancer centre, such as Maggie's, will have a pancreatic cancer support group that might be helpful. Obviously, here at Pancreatic Cancer UK, we can offer you support to help to keep you well. And this can be things like attending sessions like today, or the written information that's on our website, or accessing the support line services. And I'll explain our services in a little bit more detail in a few slides, in a couple of slides' time. But also think that when you go to the hospital, is a good opportunity perhaps to explore what services you might access to help you keep well. I think a fantastic resource is the Macmillan Information Centres, and most hospitals will have one. And you can call in perhaps after you've had your bloods done for your chemotherapy, or waiting for your chair, or in between your radiotherapy or our clinic appointments, and just say what sort of things that they can offer you. Is there something close to you that is helpful? Again, it could be things like complementary therapists, but it could be walking groups, it could be gardening groups, it could be all sorts of different things that perhaps could be helpful. But we've also got to think that alongside those sorts of emotional support and holistic support and social support, you need also perhaps some advice medically. And the people who can offer you that would be have a discussion with your hospital team, your clinical nurse specialists, in your GP practice. The GP practice may have access to things like the Macmillan nurses or district nurses, who are also fantastic resources to offer people to support to live as well as possible for as long as possible with their condition. And I also think it's really important to mention the local hospice. I understand that when I discuss the hospice, people can feel a bit alarmed, as they think that the hospice is associated with people dying. And whilst the hospice does support people as they approach the end of their life, the modern hospice movement is focused on supporting people to live as well as possible with their condition. And a key component of that ethos is offering proactive symptom control. And this can be done as an inpatient, outpatient, or in the community. And I think the hospice is something to be less frightened of. But I think that, again, let's hear from Claire and Bradley, who are going to discuss their experience of accessing support.
So I think one thing that we
top tips
haven't mentioned that we should mention is about engaging with palliative and supportive care and not being frightened of that, understanding the difference between palliative care and end of life care, because they're quite different things. And I think if we hadn't engaged with a fantastic hospice, our life would have been much the poorer, wouldn't it? You know, thinking about,
oh golly, yes,
you know, the complementary therapies, you know, the counselling that you've had. I've had some family support sessions. We had a community nurse that came to see us. She was brilliant. The psycho-social and spiritual support that can help to keep you well, as long as the actual acute medical interventions. And I think it's both of those things that keep you bobbing along. So I would really encourage people, don't be afraid of engaging with that, because there's so much, it will enrich your life.
So again, Claire and Bradley explaining it much better than I ever could. So after treatment, I think people can often feel anxious when treatment finishes. There's often feelings of uncertainty about what happens now. I'm often asked, why can't I just carry on with treatment? And to be honest, I think this is a very reasonable and understandable question. Everyone is different, and I think it's most common for people to have a break after they complete 6 months of treatment, and most people are ready for that break. And what happens after the 6 months of treatment is you will be placed on something called active surveillance. This is a period of time when you're not going backwards and forwards to the hospital and having bloods and all the rest of it so frequently, and you can focus on recovering from treatment and hopefully having some normal-ish life. But I think this feels a little bit odd after such a long time of frequent hospital visits and close observations. And I think you need to check with your team about what the follow-up is for you. What's the right follow-up for you? It might be that this is a good time when you finish your treatment to think about what happens next. What's the next treatment? Might this include a clinical trial? I think it's important to know that when treatment finishes, it doesn't mean that care and support ends. But often the care and support that will be most beneficial to you after treatment finishes isn't based at the hospital, but based closer to your home, and includes the things that we've just talked about and what Claire and Bradley have talked about. When on active surveillance, keeping in touch with your team is important, and you know, being in touch with your clinical nurse specialist is key. And again, if there's anything you're uncertain about or you have any new symptoms, letting someone know is so important. So I wanted to just share with you for a couple of minutes some of our support at Pancreatic Cancer UK. And so myself and Simon both work as specialist nurses on the support line. And so you're able to pick up the phone and speak with us during our opening hours. But you can email us and WhatsApp us also. And we have lots of information on our website, and also things that you can, lots of publications you can order free of charge, which go through lots and lots of different things associated with pancreatic cancer. We also have webinars, and the next one that we are doing is in November, and it's living well to the end of life. And if you think that might be something that is of benefit to you, please do follow the link on the slide. The slides will be shared with you after today, and yeah, join us in November. But we've also got a new exciting service that's currently being piloted, and it's focused on bringing together different people who are all affected by pancreatic cancer via online groups. This new avenue of peer-to-peer support, this is a new avenue, sorry, of peer-to-peer support. And if it's something that you think might be of interest to you, please do use the link or the QR code that's on the slide. And this is for all those affected by pancreatic cancer, including family or friends. So finally, I've done a lot of talking, but finally I wanted to think about some take-home tips from what we've discussed in the last 35 minutes. And I think that, you know, treatment is different for everyone. There isn't one size that fits all. Your experience may be different to someone else who's got the same condition. And understanding that is important. You must keep asking questions. And you ask questions tonight too, but you must keep asking questions. Don't accept, you know, don't accept not having opportunities to ask the questions, whatever they may be. Keeping well on and off treatment is a priority. And as I say, often keeping a little diary while you're on treatment can be helpful to recognise how you feel and allow people the healthcare professionals involved in your care, to proactively manage your symptoms to help you feel better. And if you have a side effect, you're not sure how to treat, you treat them straight away. You call the 24-hour hotline for any urgent advice. Or if you develop anything that you're uncertain how to deal with independently. Treatment breaks and dose reductions are normal and helpful, and quality of life is so important. You need to prioritise yourself and each other. Make sure you know who to contact if you have any questions or need advice, and get the right support from the right people at the right time. So I'd like to thank you for listening, and I hope it's been useful, and I'm happy to answer any questions at all.
Thanks, Lynn. That was really good, really helpful. From my perspective, and it's probably no ground, I would certainly encourage you to access help in a timely way. Not be afraid of palliative care services. They're certainly not the end of the road option. And when they dovetail with your oncologist, as I have done throughout my career, we can make a big difference to your symptom management, to your emotional and psychological well-being, to help you through your treatment and beyond. So really, really would encourage you to engage with all of the services we've highlighted there, your district nurse, your GP, all those players will come into effect and support you, because everybody has their own expertise that you can tap into and use. So,
and also what you know, everybody who's joined this call tonight will perhaps have a different need. as well, so understanding exactly what is available. And some people want to just meet up with people, like the gardening groups and all the rest of it. It's about accessing things that are most useful for you, but also that keep you well.
Right, we've got quite a few questions now. So
Good.
there's a few that are similar.
That's all right.
I will try my best to sort of combine them. We've had a question from El Colgate. What options are usual after first-line treatment is completed if it's been effective in reducing tumour and distant disease? I know we covered that in
I can
Lynne's
cover it
session.
in a little bit more detail.
Yeah.
Sorry. So it's a good question. And like thinking back to the slide about what happens next, it's an element of that, really having that conversation at that point. When we don't know what chemotherapy will be beneficial to what person. And so this is why we do courses of chemotherapy. So the 6 months course and the scans along the way. If your scan showed that the chemotherapy has done its job, so you've completed the 6 months treatment, the chemotherapy has done its job, it's controlled the cancer. Often people want to see reduction in the size of their cancer, but I would just stress the aim is to control. So if your scan shows stable disease, I think that's very positive. So at that point, that first lot of treatment would be called, very obviously, perhaps, first-line treatment. And then that scan shows stable disease. We don't know how long that stability is going to last for, which is why active surveillance is so important. So what would tend to happen, everywhere is probably a little bit different, is that you'll have regular scans. So my practice was that I would see you in clinic with blood every 6 weeks, and you'd have a scan every 12 weeks. And the aim is to pick up when that cancer may change. So again, we know that it was stable at the end of treatment. We don't know how long the stability will last. We keep close observation so that we can act in a timely way when the cancer starts to change. And then we would have a discussion at that point about what the next steps might be. Because sometimes the first-line chemotherapy stability can last a good long while. So it might be that you consider re-challenging with the same treatment. However, it's common that the stability may change within 3 or 6 months, and it might be at that point that we talk about next the second line treatment. And you'll remember perhaps from the slide the different names of the drugs. So we would consider what else is in our arsenal, if you like, what guns are in the arsenal to fire next. So it might be that we consider a different type of treatment. That might be an opportunity, that time, to talk about, are there clinical trials available? And I know we're not discussing clinical trials in this meeting, but I think it would be amiss of me to not mention it. That would be a point where it might be that you think about asking the team about clinical trial options. I don't know if I answered that. I did one.
Because there's been quite a few questions around clinical trials. So
okay, well, I'm happy to answer clinical trial questions. Yeah, ish.
I think there's questions around, are they available? Is it a good idea to ask about clinical trials when you're speaking with your oncology team?
100%, yeah.
Are they available privately? Is there any benefit in terms of speed going privately with accessing things like trials or treatments?
It's hard. Every case will be an individual, and it might be that people who are asking these questions want to give us a call on the support line to discuss further. However, I'll give a short take on that, if that's okay. So I think clinical trials are important to explore with your team at each junction about treatment. And I also think it's important to ask the question about your biopsy and has it been sent off for genomic profiling, because that can open up doors for treatments, novel therapies, clinical trials, things like that. Stressing that it's very small amount of percentage of people with pancreatic cancer that have a genomic mutation that's targetable with treatment. But these are things that we should absolutely 100%, I'd advocate having a discussion with the team about. Mentioned briefly about private access to clinical trials, and of course there are private options. Again, I think with clinical trials, asking the team, but also giving, it's very difficult to talk about it broadly in this setting, but I would be more than happy to have a chat with people, as would us all on the support line, on individual basis, because there's a lot to it to pick out about the options regarding clinical trials.
We've had a couple of questions around peripheral neuropathy.
Okay.
What helps with peripheral neuropathy? One was just a general question, and one was what can help that isn't medication, it's not drugs.
So there's a lot of work being done about peripheral neuropathy, and what we know is actually we want to prevent peripheral neuropathy. It's very hard to treat it once it is there. And how we best manage peripheral neuropathy when on treatment is by dose adjusting. But it's a very difficult side effect of chemotherapy, and it's an accumulate to manage once it's already been established. So what we want to do is prevent it from getting any worse, and how we do that is by adjusting. Pardon me. It's usually the oxaliplatin or the Abraxane that causes it, and the things that we have to consider with people who've had FOLFIRINOX, and they maybe go on to a different treatment, or that causes it, about minimizing the effect. But it is a long it causes, it's a long, it's a, what's the word I'm looking for? It's one of the ongoing complications long-term of chemotherapy in pancreatic cancer is peripheral neuropathy. Yeah. And you're having those discussions about the things that you enjoy in your life is a really important thing when considering the drugs that give people peripheral neuropathy. I've looked after people who really enjoy playing the guitar, and that can be quite difficult. So having those discussions, but adjusting doses is the best way to manage peripheral neuropathy in truth. Yeah.
And therefore, one of those things, if you are having it as a symptom, not to keep to yourself, it should be one that you would report to your team.
I would advocate reporting anything that's different for you to your team. It's much easier to prevent peripheral neuropathy from getting worse, or prevent the nausea impacting your, ability to eat and drink, etc., if we know about it. Sometimes it's not so straightforward. And I'm sure the people on the call who have had treatment can attest to that. But sometimes all the drugs in the world, sometimes, side effects can happen. But yeah, escalating any issue as soon as it happens, communicating, having someone that you have at the hospital that you can talk to about a little niggle or a big niggle, and prevent it becoming an emergency, or prevent it being something that impacts your everyday life.
I'm not sure whether this is something we can tackle now, but there's been a couple of questions around immunotherapy.
Probably not something to tackle, but yeah, it's a discussion to have with the team. I think immunotherapy has been challenging in pancreatic cancer, in the treatment of incurable pancreatic cancer. And so, so it would be something to have a discuss with the oncologist about. I'm not sure there's many options in the field of incurable pancreatic cancer. Again, probably best to talk on the individual basis, and like I say, drop us an email, a WhatsApp, whatever. And yeah, I'd be happy to have a chat, as will my colleagues. Yeah.
We have a question here around radiotherapy and whether it's available where metastases have occurred at multiple sites.
So, a very interesting and current question, and something that we commonly ask about. And so, because radiotherapy is a localized treatment. So what that means is it only treats within a field of range. It's usually one area. That poses challenges to treating multiple areas that might be there for if someone has, for example, pancreatic cancer that's spread to their liver and abdomen or something like that. So it's very difficult for radiotherapy to treat all of those areas because it's a localized treatment. And so systemic treatments are usually the best thing to propose for people with widespread disease. And how I describe it, it might be not an analogy that's helpful, but is like chemotherapy is like weed killer for the whole lawn. So it'll pick up weeds anywhere or cancer anywhere, it'll treat them. Whereas radiotherapy is more like just picking up a weed as you walk around the garden.
We've got a specific question here asking, is it possible to have a second round of FOLFIRINOX after the first 6 months treatment?
So I would say that it is something to discuss with the team. The things that would be my considerations on that would be the effect that the chemotherapy has had on the cancer and the person. You know, sometimes I have given people chemotherapy, FOLFIRINOX at an adjusted dose for a longer period, but it is based on the individual. And so it is not common practice to do that now. But everyone is different, and it's worth having those conversations, and it's worth asking the question and asking why not.
We've had a couple of questions which are similar in terms of, if I'm understanding them correctly, is how do you work out if the chemotherapy is working or not working? If the tumour grows during observation, does the chemo does the chemo start again? I know you've talked about this in some detail in terms of this being quite an individual.
It is, and also I think it's
issue.
one of the most challenging things for people because often people can feel that on chemotherapy something's happening. You know, we're controlling it. Why would we stop that? How do we know when the cancer is changing so that we can act on it quickly? There's all that uncertainty, and that's why that period of active surveillance is so important. That what I would say is that it's unlikely for the individual to know if anything is changing, but unless, you know, which is why you have bloods done every 6 weeks and regular scans. However, it would be if you've got any niggly problem or any pain that's getting worse, or you become jaundiced or whatever, doesn't necessarily mean the cancer's getting worse, but it's about escalating it to your team and ensuring that that is investigated as quickly as possible. Again, just because you have pain or you become jaundiced or you have a new niggle doesn't mean the cancer's growing, but it's you know, we have to be responsive to how you feel. So I would want to know from the individuals who are on an active surveillance if they had anything that was worrying them. But that uncertainty is very difficult. And as I said in the slides, people it can feel a little bit like, you know, you as perhaps burdensome going to hospital all the time is, it can be quite reassuring that you've got that feels like a security blanket or a safety net, or, you know, because you're having regular assessments and interactions with people. And that's why I would advocate keeping in touch with your team, but also having the support of the community teams, because as you mentioned, Simon, picking these run parallel. So, you know, Macmillan nurses or district nurses used to ring me up about people that they were maybe worried about, and then we would you know, work together, collaborate with the person to decide what was best for them, really.
I know I would always work very closely with people like yourself and also the oncologists in order to give the people that we were looking after the best possible chance of not only going through treatment, but going through it well and living life as best they can.
Yeah. And I think that that's the focus. I think that treatment is one spoke of the big wheel of full of analogies, aren't I? Big wheel of being well. It's and there's lots of other things that have to work alongside that as well.
I hope that answers the questions from Antonia and Duncan regarding efficacy of treatment. And also around symptoms of pancreatic cancer versus side effects of treatment. It's not easy to pick up, but it's all about surveillance and allowing people to assess you.
And I think that the whole thing about what's a side effect of chemotherapy and what's a symptom of pancreatic cancer, that active surveillance period is often that time. Sorry if you can hear my dog. We would expect people to feel better inverted commas, recover from their chemotherapy within, even a couple of weeks, really, that people notice that they feel better. If we weren't still feeling rotten, or we still had things that were niggles that hadn't improved from stopping chemotherapy, well, maybe that needs to be more of a managed as a symptom. But they go together. It's hard for people to pick out, and I don't, and not sometimes it's good for us to pick out as healthcare professionals, but for you experiencing, it doesn't matter if it's a symptom or a side effect. Escalate it, get it investigated, get it treated, proactively managed. So you feel as well as you possibly can. But if I've not really answered the question, you can, do let us know. And like I say, you can give us a call on the support line.
Yeah, I think there's a couple of questions really that probably would be better suited to the support line, which we're sort of answering in the background, and hopefully that's okay for the people who've answered those questions. Quite a specific question here about what is platinum's use in chemotherapy.
What? Say that again, sorry.
What's the role of platinum?
So platinum is a heavy metal compound, and so different chemotherapy is, like I say, a blunt instrument. We use different combinations of drugs because each one of the drugs perhaps has a different impact or a bit different effect on the cell cycle, and that's what we're wanting to do with chemotherapy, is interrupt this cell cycle and stop the cancer cells from replicating. And we know that good cells and bad cells, so cancer cells, the reason we give in cycles is to have the maximum effect on the cancer cell, and we know that good cells can recover quicker and take a bit more of the chemotherapy battering than the cancer cells. Platinum is just another type of chemotherapy, so it's a heavy metal compound. So oxaliplatin is one that's commonly used, but we also use cisplatin for people who have a BRCA mutation, because that is known to be much more sensitive in that respect. So it's about, each drug has a different impact on how the cell divides. How we use the drugs is having a maximum effect on that cell cycle. That's why we use them in combination, and platinums are just another type of chemotherapy.
We're coming towards the end, but I'll try and squeeze another couple of questions in. Are there any tests to see which treatment might be most effective? I'm assuming that's chemotherapy.
Good question. Excellent question. So I'm glad you've squeezed this in. In truth, not with chemotherapy. So the things that are most exciting to a nerd like myself in oncology is that, personalized medicine. So what is it that makes people with a certain type of cancer have an effect from a certain type of treatment? Chemotherapy is a blunt instrument. We don't know who will benefit from it and who will not until we start giving it and scanning and all the rest of it. Whereas actually what what genomics can help us do is target certain cascades in the genome, which is our DNA. And sometimes when there is a cancer, there can be a little hiccup in our genome, and that gives sometimes treatments are targeting that mutation, that hiccup. So yeah, so how do we know people will benefit from chemotherapy? In truth, we don't. How we know that chemotherapy is useful in treating pancreatic cancer is by doing clinical trials and comparing different types of treatment, and then comparing how people respond to it.
That's great, thanks, Lynn. There are a couple more questions, and I'm just wondering whether they may be better either emailed to us so we can answer them specifically, because we've run out of time now to go into detail. One was regarding off-label drugs. Another was around the availability of NanoKnife in the UK. And also,
okay, so I can talk about NanoKnife in 2 minutes.
Yeah.
So the availability of NanoKnife. So NanoKnife is a type of treatment that is not standard of care for people with incurable pancreatic cancer. It's called IRE, and it's using, you're going to have to remind me, I might have to Google what the IRE stands for. Now I've been put under pressure. But IRE, or NanoKnife, is using electrodes, I think, like electric frequency, but it's really not been well researched in pancreatic cancer. And it is also one of the treatments that is used, it's more within localized therapy. So it's been around for a good long while, but it's not available on the NHS routinely. There are certain centres that are doing it, but it's not really well evidence-based. That's changing, because I believe that they're going to start thinking about doing a clinical trial, but I don't know when that will open. So it's something that we've been talking about for probably 12 something years, but it's not something that is standard of care for incurable pancreatic cancer at this point. There needs to be more evidence to support its use, and hopefully there's going to be a clinical trial open, but I don't know when that might be. If you want to talk about your particular case about IRE, it's, like I say, it's worth giving us a call to have a look, but that's the general consensus of that treatment. Not used as standard, not good evidence base at this point, but hopefully that will change.
That's great, Lynn. I'm glad I asked you that one. That brings us to the end of our session this evening. I hope it's been helpful. I hope you found it useful. We've covered a lot of information, and you might not have been able to take it all in. There may be questions that have come from the questions we've asked that you'd like to talk through. So just to reiterate and bring to your attention again that we do have a support line. You can speak to myself, Lynn, or one of the other specialist nurses, and that number is 0808 801 0707. You can email us at nurse@pancreaticcancer.org.uk, and obviously with an email you can be really specific about the questions that you want us to answer, and then we can send you links with information that will hopefully give you what you need. We've got a new WhatsApp service, so if you're wanting sort of quicker responses, perhaps shorter amounts of information, then that's a good service to tap into. That's 07816 408 416. There's a wealth of information on the website as well. Lots of things around specific types of chemotherapy that goes into detail. So please access that. If you're not sure what to do, you're not sure how to access it, please give us a call and we'll help you as best we can. Thank you all again for joining us. I hope you have a good evening.